Welcome, everyone. Thank you for joining us. My name is Julie Cullen, and I'm the managing editor of American Nurse Journal, the official journal of the American Nurses Association. Healthcare leaders have been warning for years that U.S. hospitals face a growing nursing shortage. One widely cited study projects a shortfall of 510,394 registered nurses by 2030. The main reasons are varied, but some groups, such as the ANA, point to waves of retiring baby boomer nurses, an aging population requiring more medical care, faculty shortages that limit the capacity of nursing schools to accept more students, and more nurses moving away from direct patient care or leaving healthcare altogether because of stress or burnout. This perfect storm of causes is felt acutely by those charged with the daunting task of nurse staffing and retention. Today, we've convened a panel of nurse leaders and industry experts for this video series to share their recent frontline experiences. We'll explore the best practices they've followed and the creativity and problem solving they've brought to the workforce shortfall. We'll also discuss the technology tools that have empowered them to devise staffing strategies that improve healthcare working conditions while ensuring patient care and mitigating fiscal impacts. Our panelists today are Daniel Bowie, Allison Bruckner, and Bryan Dickerson. Bryan, how can CSOs be empowered to evolve from tactical firefighting to strategic problem solving by being able to take on an enterprise-wide staffing data and processes?
Well, I think what you hear from Danny is innovating and taking a leap of faith, and I think Allie the same thing. That there are things you can do and there's technologies to do. So following the same path of staffing that a lot of organizations have followed for 30 years is not the answer. You have to look at it and you have to have the courage to go out and do something different. And that can be with technology such as what we provide in Hospital IQ. It can be organizational design such as some of the things that Danny has. But it has to be something. And one thing that Danny said early, which I completely agree, and I talk to clients about all the time, that there's no magic answer, there's no magic bullet to solve this problem, and there's no one thing that's gonna make dramatic differences. You have to start, and you have to start picking away at it and make a difference. And if you don't, you're just gonna go down the same path. And I think I've been doing this doing healthcare staffing for 30 years. I think this is probably one of the most difficult times I've seen, and it's, as Danny says, a perfect storm because there's the massive amount of patients that come in, and all the clients I talk to talk about the fact that because of many factors with COVID and financial issues, the patients are sicker than they were before, and they're more difficult and more demanding. So everything is just that much harder. So you have to look at technology. You have to look at your processes. You have to, be willing to say what we did before is not working, and let's do something different.
Which specific hospital IQ enterprise system features come to mind that best facilitate the sort of system-wide collaboration and resource sharing that the present acute staffing environment necessitates?
Well, I think there's a combination there. First of all, it's about creating a sense of transparency across your organization and where your staffing challenges are, and being able to look at the big picture. But not only just across the organization, but be able to create that transparency based on what makes the most sense to share and work together from a staffing standpoint. So if it's within a particular campus or a particular region at an organization, or even a region and campuses across service lines, where being able to see your critical care needs across multiple hospitals and multiple facilities, so that you can really understand where are your shortages, but also be able to see in advance with using forecasts to see where your problems are going to be days ahead. You don't wait and leave yourself in the reactionary mode of just trying to juggle things at the last minute. So doing that, and then also we add this communication infrastructure to our system that allows the staffing office and the units to communicate and share information about, what are the needs of the units, what are the capabilities of the staffing office, what are the compromises needed, and what do we need to do to make it happen? Because, the one thing for sure is every day is a new situation, and every day there are strategic goals from a patient flow and what the organization needs to accomplish, and staffing has to be part of that. So having that transparency and that ability to communicate is extremely important. Put together a quick demo here of our software. First, I want to show you what we call our workforce plan, which is really the view into staffing into the organization. So what you can see here is looking at these units are, we show what the staff is required based upon the census, and we show how many staff are actually in the schedule and give a variance. The important thing that I want to highlight, though, is a lot of organizations have this view, but they don't have the flexibility in this view to look at the organization from many different angles. Right here, I'm looking at a what I call my acute care view of the organization, but I can go in here and I can look at the critical care. So I can see critical care here, which is actually divided across campuses. So we can look at the staffing, and I think this is very important in the world with such difficult staffing. We can look at it from just about any angle that you want. If you want to look at it across campuses, you want to look at it within service lines within the campuses. So if you have 3 campuses and that you want to look at just the ICUs, you can do that. You can look at med-surg units across campus. We can throw in a region where it's a region, the campus is within a region, and so on. So you have a great deal of flexibility. And we can do that through our container system, where we define containers of locations and tag them like this for the critical health care. Or we can simply just define them on the fly, where we can look at all these units, pick which ones we want to see, and look at them that way. And we can slice this thing up almost any way you want. And that gives that flexibility for to be able to see where you might be able to share staff and where you might be able to move people around. So I'm going to go back to the view I had set up. And so within this workforce plan, we have a lot of other data that's available. And I'm just going to go through this extremely quick. First, we have information about the acuity of the unit, and we can pull this from an acuity system, or we can actually enter that in manually. And we have information on discharges here, so we can actually see what are the pending discharges. And that's important when you have situations where you might not have enough staff in your resource pool to provide everybody what they want, but you can look at this information to see who you might distribute the resource to. We have our sidebar here where we can look at the staff. We give indications on different things about the staff. If they can't do COVID-like duty, who's floating, who's in incentive pay. If you see that little dollar sign there, that's great information. We can look at orientees and see who's in an orientees, and then we can see how many shifts they work, which is extremely important when you're again trying to figure out how do I add my staff when I'm limited staff. The other really cool thing is right now I'm looking at this in a single day. We can look out into the future by simply saying, I'm going to look at Tuesday through next Wednesday and apply. Now, all that information that I just showed you, and I'm not going to go back through it all, is available into the future. So now I'm looking at tomorrow, and I can see my variances. I can see all the different information. I can look at if there's any planned discharges. I can see how my staffing is. And that's where we really want to focus on people becoming more proactive, starting to look at staffing in the future. One thing that I was just doing some research on a few of our clients, and I'm finding is about 10% of the time, there's still shifts where the number of staff in the schedule are actually more than what's needed based upon the forecast and then based upon what is actually happened. So there still are opportunities where you might be able to move people around based upon the information in the future using our forecasted census volume. I also wanted to go into here, and I'm going to go back a day real quick. I wanted to talk a little bit about our communication infrastructure, because that is also very important. And most organizations today, when you're doing the staffing process, there's a communication that happens between the unit and the staffing office. It starts with the staffing office wanting to know from the unit, hey, is the information in the schedule accurate? So they call out to the unit, try to find out that information. Usually they're trying to talk to the charge nurse who's trying to get, work with their team, keep patient care going. So there's a phone tag or there's messaging going back and forth. So what we've built is a really cool communication infrastructure that allows first it allows these notes to go back and forth. So by sending notes back and forth, we allow the charge nurses to actually log into the system. And I'm gonna simulate that simply by clicking on this list right here. So this is the interface the charge nurse has. So they log into the system. They can look at the list of people that are scheduled to work. They can do quick edits if they need to, or they can just simply add notes here. And you can see here that I added some notes about information needed for sitters and so on. So they can add information about that. And what this does is it creates a layer of transparency. So when I come back here, you can see that I have a number of notes here, and I can click into those. And the really great thing is you can see who read the notes. So you can see, and we see this in our system where there's a lot of people looking at this information. And this tracks, how we got to our staffing level. And it's all done where on a mobile device by the charge nurse, where they can log in when it makes sense for them, and they can make the updates and communicate to the staffing office and back and forth. And what I did grab was I put together I grabbed a sample of the communications from one of our clients and de-identified it. So, but it just shows you here, it's like, good morning, we're over by 2 RNs. We need 3 sitters though, thank you. And, so then it gives the information about what sitters are going where. And then the staffing office is saying, hey, we need to send an RN to 6 East, send an RN to C4, thanks for, and so on. And then we have this ability to put little icons or emojis on there, which makes it kind of fun. But here's just a live example of the notes going back and forth. So that communication infrastructure has really created extra transparency. It's illuminated and gives access to leaders to how the staffing process flows. Some cases I've had clients that have uncovered some training that was needed in policy and how staffing was applied, and made changes to it, because where you're just doing phone calls, you don't have any history there to be able to track that. Lastly, what I want to go in is looking at our patient list. Now, this is stepping in a little bit into our patient flow process, but it's very important here to understand, because we have behind the scenes all kinds of information about the patients. And we have things like that we forecast, like missing tests. So if you can see here, it says a CT spine with 85% next to it. What that is saying is that before this patient is discharged, based upon the type of patient, the physician, all the different attributes, we're 85% confident that they're going to need a CT spine before they're discharged. The whole idea here is to make sure discharges, barriers to discharges are actually identified in advance. And somebody might ask, why would you bring that up in a staffing conversation? Because today, one of the key, most important things is if we don't want to miss discharges, we don't want to have patients there longer than they need to, because that requires staff to take care of them. Yes, there might be another patient come in, which will require staff, but you're getting more patients through the care continuum. We can do things in here like we can communicate with people externally, which I think is extremely powerful. And here, I set myself up as a brother of this patient. I received a text saying, "Hey, would you pick the patient up?" And I responded, "Yes, I would at a certain time." So that can be seen through the system. So it automates some of that communications. So it's all about how we bring all this information to bear so that we can make sure that we are moving the patients through the continuum, making sure that that patient movement is actually transparent, and we can see that during the staffing process so that we can better make decisions on where do we need to move staff, considering what are the priorities of the day.
Thanks, Bryan, for your time today and for sharing your insights. We hope that this exchange has provided some pragmatic, actionable steps in these extraordinary times as we strive to optimally staff to best serve patients. Thank you, everyone, for joining us today.